Okay, we're at 1:30, so we'll get started. I'm aware that everyone's got a busy schedule, but we will continue to let people in throughout, just in case anyone is running a bit late. I know that a lot will be busy with a lot of other appointments. So thanks again to everyone who's joined. Please note that today's webinar will be recorded so that a video can be sent around to all registrants after the event. Please also do keep an eye on the chat section during this session. We'll be putting messages on there. They'll be coming from my colleague Ralph, and we'll be taking questions which you put on the chat as well and addressing them at the end. Finally, we'd just like to request that everyone make sure they're on mute during the presentations, please, just to make sure that we don't have any background noise causing distraction. Thank you for that. So today is the 7th episode in our series of online training webinars called Mastering Seating Assessments. And today's event will be all about the provision of seating for people with neuromuscular disorders, which includes conditions such as MND and muscular dystrophy and others, but we'll go over that a bit later. We're very pleased to welcome Liana Pretorius as our guest speaker today too, who I will introduce in a few minutes. So I'm sure you're looking forward to hearing from Liana as much as we are. So briefly, here we have today's agenda. We are going to look at the various risks and symptoms that people with neuromuscular disorders live with that should be looked for and considered when specifying seating for them. We'll also discover how to support them with proper postural and positioning solutions, enhanced mobility, and much more. We'll learn about different chair types that are available, the functionalities these can offer to help you enhance the lives of your clients. And then this will be brought to life at the end by our very own in-house seating specialist, Ben Sterling, who will demonstrate what some of the functionalities we've discussed, what they actually look like on actual chairs. At the end of the webinar today, we will have a live Q&A session. So please keep a note of any questions you'd like to ask. You can pop these on the chat as we're going along, and we'll pick them up at the end. Otherwise, you are welcome to unmute during the Q&A and ask them in person. So we'll let you know when we get to that section. Before we get started, I'd just like to go over a little about our company. Some of you may have joined our webinars before, but for those who are joining for the first time, we've been supporting the healthcare sector for over 50 years now. We're previously known as Yorkshire Care Equipment, which some may recognise that name, but we're now called Vivid Care because we're working right across the country, both in hospitals and the community. So our mission at Vivid Care is to enhance lives through advancing care, as you can see there. And our focus is on providing specialist care seating, profiling beds and hospital beds, and then also mobility equipment. So we are really working as a team every day to enhance the quality of the lives of people we work with and end users and clients, but also to make your life as the healthcare professional easier and safer as well. We're actually part of Core Care Group. So our sister companies include Innova Care Concepts, who specialise in hoisting and installed healthcare projects. And then there is Aquadapt, who help with home adaptations. So without further ado, I'd like to welcome Liana Pretorius. She's got a huge amount of experience in occupational therapy, and she's worked in it for many, many years. So I will just stop sharing and hand across to you, Liana. Welcome. Sorry, we're not hearing you, Liana. I think you might still be on mute. IT is a wonderful thing. It always works during the preparation. Never seems to work at the time. I'll give you a minute to. Oh.
Right. Hello, am I in?
There we go. We can hear
Yay!
you. Well
Apologies,
done.
it worked perfectly fine when we tested it, but for some reason it's not happy. Good afternoon, everybody. So, as Braden said, my name is Liana. I've been an occupational therapist for about 30 years. As you can tell by my accent, I'm South African. I grew up in South Africa, studied there, and then came and worked in the UK for the last 24 years, specifically in neuro and community neuro. So I'm just going to share, and hopefully, can you see my slides?
Yep, it's just loading up for me right now. I think it might be at the end of the slideshow.
Oh, I don't know why it's doing that. That is very strange. It was all working fine.
Yes, it was.
Right, let's try that again. Is that better?
Perfect. Thank you. Yeah.
Fabulous.
Perfect.
Okay. So today we're going to talk about neuromuscular disorders. Now, the neuromuscular disorders is basically a huge, broad range of conditions. And the main thing that sort of forms together with it is that it's all to do with the muscles, and it all has progressive disease. So there's about 70 different type of disorders that we know about, and many of them are still unknown. There's many genetics, so there's a lot of testing and stuff that goes on around genetics. Neuromuscular disorders can be diagnosed either from babies all the way through the lifespan into adults. And it's interesting to know that about a third of patients with some sort of muscular disorder have not actually have some specific name for their condition. But we know it can run in families, and also it can occur in any point of your life. So the most commonality for neuromuscular disorders is that it involved the muscles, and it will vary which bit of the muscle and anything around it depending on the diagnosis. As we said before, it can happen during childhood or even later in life. And what we know of with some neuromuscular disorders, it's going to take less stress to damage that muscle and take much longer for them to repair. And so therefore, it's really important that we think about that when we think about what we're going to put people to sit in and what they're going to do. Sometimes also we get asked, well, why can't I just do exercise, and my muscles will get better? But you can see why that if it's the damage that's either with the muscle or the nerve supply, that sometimes you're not going to be able to make it any stronger. And that's why we think about our muscles and what it does, how important it is, that it helps us move around. It helps us keep our posture. It works with our energy level. So we have to think about also how it holds our joints in place. So in terms of generally the neuromuscular disorders, there's about 4 problems that you can group all this big order of conditions in. So the first one is an actual problem with the muscle. So that is all your muscular dystrophies. And I found this really interesting. I think it sort of shows the different type of muscular dystrophies. I think the most common one we tend to see is the Duchenne's, which tends to be more males. The other one is, very interestingly, is where the neuromuscular junction. So that is where the nerve and the muscle meet. And myasthenia gravis is probably one of the most common conditions where this is where the problem lies, because what happens is, in order for the nerve to transfer the message onto the muscle so that the muscle can work, we have certain receptors that moves sort of between the nerve and the muscle. And what happens in myasthenia gravis, we produce an antibody, which basically plugs onto this receptor that then makes it much harder for it to attach and send the message across. And that is why we see with the myasthenia gravis patients, they tend to have sort of periods of weakness, and then they get a bit better. And we know their symptoms will fluctuate, typically around end of the day when they've done a lot, or when the weather is really hot, or they've been unwell, they've got a cough or a cold, or even sometimes for the women, if they have any, when their periods is on, we do see that will have an effect on that, how the message gets sent. The other one is the nerve supply to the muscle. So these are the Charcot-Marie-Tooth types of disorders. And they tend to be more the peripheral nerve, so the nerve outside of the spinal cord, where there's problems with how it sends the muscles along. And there is quite a few different types of Charcot-Marie-Tooth. And then last but not least, probably the one thing we see the most common is the anterior horn cell in your spine. So in your spinal cord is sort of where the nerves comes out and what helps relates it. So spinal muscular atrophy and the motor neuron disease, these are the diseases that will either be the anterior side, so the front bit of that spinal bit, or the back bit. And that's where the problems lie. So prevalence-wise, St. George's did research. They looked from the year 2000 to the year 2019, and they found about approximately 13 million people were actively registered each year with a neuromuscular disorder. And they're saying because it was higher amongst males than females, not entirely sure why. I don't think I've seen exactly why. But they found most common classifications was the Guillain-Barré's, myasthenia gravis, the muscular dystrophies. And then they say overall the prevalence grew by about 63% and is mainly seen in the older populations. And the myasthenia gravis incidences has steadily risen, but overall the incidences of neuromuscular disorders tend to remain pretty constant. So if you look at why do they feel like it's gone up, why does it feel like it's gotten worse when we think it's sort of been constant? It's probably most likely because we're getting better at coding it, but also getting better at diagnosing it, and also the advances in technology allowing people to survive things now much longer than what they used to before. So the most common types of neuromuscular disorders that we will see, and in my practice, I can tell you this is exactly true, tends to be the motor neuron disease, the spinal muscular atrophies, or your different type of peripheral neuropathies, myasthenia gravis, muscular dystrophies, as I said, inflammatory stuff, and all kinds of other weird pathology stuff. Now, the main common, as I said already, thing is that it's a progressive muscular weakness. But the most other common symptom that comes with this is muscle fatigue. And what we need to think about is they can either be progressive, these fatigue, so the fatigue gets worse over time. So as the day goes on, think about the myasthenia gravis type patients who get weaker and weaker as the day gets on, or it's quite variable. It can change, and also sometimes it can just be quite persistent. So that is why it's really important we keep that in our minds about why does it matter how patients sit and where they sit. And I think we need to think about good sitting posture allow us to perform our daily stuff. It allows us to have a balance between doing things, being stable and being comfortable. But we have to really think carefully about what is the consequences of poor posture. So it means that people will be in pain. Potentially they can't do the things they need to do. They can't do the things they want to do. Long term, it can lead to skin problems, pressure problems, and for some people also respiratory problems. And inevitably, it can lead to death longer term if we don't get that right. So the support from the right chair can help reduce our poor sitting posture and help us to just manage our pressure. So I always say the main thing before you do anything around seating is you have to ask, what is the patient going to get out of sitting out? What is it? And it's different for everybody. And that is why it's a very important question to ask them and to say, well, what is it? So what if you can sit out? What will the sitting out do for you? So for a lot of people, it's about improving their ability to do some functional task, whether it's that if they're up, they can be on their laptop and they can be on their social media, or they can feed themselves, or they can have a drink, or they can actually use the telephone. It also, think about whether it's going to limit any adverse effects of muscle imbalance. Think about the skin and breaking down so that we prevent any skin breakdown. Also, if people, we see this a lot, if they're in bad positions when they're eating, so lots of our neuro patients have got pegs in, which is the feeding tubes into their stomachs. And if they're not in good position, they all end up having really bad digestive problems, which could go into respiratory problems. But I guess the main thing is managing their fatigue and making them as comfortable as they possibly can. Because if we're tired, we don't enjoy things. So if the goal is they want to sit out when the grandkids come, so they can enjoy playing with the grandkids, if they're not well supported, within a couple of minutes, they're tired, they're not going to enjoy it. So I'm a firm believer in having a model. I'm an OT, we love a model. And the PEO model is the model that I use for all my seating assessments. Because what it does, it gives you that holistic approach. It also gives you a very personal approach to this patient, because you have to think about each aspect. One size does not fit all in seating, and that's very important. So I personally prefer to use the PO model, which looks at the person, their occupation, and their environment. So if we sort of just has a brief look at the person, so we need to think about their age, their general health, their body weight. Can they sit? How much support do they need? How independent are they? How are they going to transfer? Are they in pain? Does it impact on their sitting? Psychological, very important. How is the patient's mood? We see a lot of patients and they are so depressed. They just don't want to do anything. So they stay in bed. And it just sort of makes all this so much worse. But being in a good chair that allows them to do stuff helps with that. Think about any other things they might have. You know, have they got contractures? Think about sort of where down this line of the progression of their disease they are. Is there muscle wasting? Do they already have skin problems? What continence issues have they got? And then, of course, we said again, fatigue and tolerance. How long will they tolerate sitting in this chair? There's no point sitting someone in a chair that's not going to support them, and in half an hour, they are so tired, they are sort of wilting out of the chair. The other big thing around the occupation is, what is it? What is it that they want to do? You must remember, we are human beings who like to be purposefully occupied. That is what gives us purpose in life. And therefore, the things we do is very important, and how we support us in our chairs to be able to do them is really important. Also, having a set routine. Is there set stuff? It helps, especially if you've got fatigue management program that you're going with them. So they sit out for a bit, then they have a rest. And thinking, how does that work in? We have lots of patients that still work, and thinking about how they can manage to do their work, still be productive. Then think about their leisure task. What is the things that they do that enjoy them? And what do they do that promote their health? Then think about the environment. So culture is really important. Thinking about the society in which this person lives in. Lots of patients say, well, I don't want my chair to look like I come from a hospital. The other thing is, where does it actually go? Is there space for it to go? What does it have to work with? Does it have to work with a table? Do they have communication aids, eye gaze, that type of thing that has to be, be put in front of them? What time of day would they be sitting out? And do they need to do any type of virtual communication? Now, people with neuromuscular disorders, it's going to have a variety of things that will affect them. And as I say, it's such a huge field of problems that the main thing you need to do is to think about how what you currently see, how that will affect what they do. So sticking to the basic principles, thinking about the height of the seat. When they're going to be sitting, do they need to have their feet on the floor? Do they need to have a foot plate? Think about the footwear they're going to wear. It's nothing that annoys me most when I turn up and they've got just these little slippery things on, when actually they might want to put their boots on. Why not? And you need to think about that, or they're in trainers, and how that changes the height of how they sit. The other big thing is the seat width. In order to give them enough support to prevent them from leaning, they need to be nice and snug. But sometimes we see people, there's too much space, and what they will do is they will wilt, as I like to call it. Or it's too tight, and then they feel really squished. Seat depth is also very important. So think about how long is that femur, because you want to have at least about 2 fingers between the back of your knee and where the seat starts. So there's a little bit of space. Too much space and they will slide. Not enough and they will feel quite cramped. The armrest is also very important. You need to really make sure that you think about, when they have their arms on the armrest, is that their shoulders is well supported. Especially think about our Duchenne's and our muscular dystrophy patients, or motor neuron disease patients, where their shoulders can literally hang out of the socket. They have been subluxed. And some of them don't like to wear the shoulder supports we give them. So using the chair to really support their shoulder joints, keeping them in nice alignment, is really, really important. Then also the handset. If they can still use the handset, can they use it with any pain or discomfort, but also thinking about which side does it go onto? Can they actually safely operate this or not? The back should be high enough to really support their upper limbs. And then also very important, think about the fabric that you're going to be on. Consider absolutely the continence. Sometimes people say, I feel on some of the Dartex things, I can feel a bit sweaty, but the latest things are really well set up, so people don't tend to have that. And then there's more continence that becomes the problem. It's always important to set, as I said, clear goals of your client, your carers. What is it that this is going to achieve for them? Because there's nothing as bad as you spending all this money and it's not what they thought it was going to be. You need to also manage expectations. So funding, it really varies. You might have, like we've got local community equipment stores that will only fund a certain type of chair. And then you might have to either go privately. We've got lots of patients who prefer certain types of chairs. And we do stuff like we go to charities or the families do fundraisers. There's a lot of GoFundMe pages. We've got people. Sometimes if people's on continuing healthcare, we're able to get funding for that through continuing healthcare. Yes, and I think that is my lot.
Brilliant. Thanks a huge amount for that, Liana. As you say, there's a huge amount to consider, but that's a very helpful overview. I'm sure I've learned a huge amount in it myself. So just a reminder to everyone, please, if you do have questions so far, you can pop them on the chat at any time and we'll address them during the Q&A at the end. For now, I'm going to hand it over to our in-house seating assessor, Ben Sterling, and he'll be using some of the chairs from our own range to demonstrate what some of the functionalities we've discussed look like and how they can be used to support people with neuromuscular conditions. Over to yourself, Ben.
No problem. There we go. Good afternoon, everybody. Just a quick thumbs up from the first person just to make sure you can hear me okay. I'll just keep an eye on the chat. Okay, wonderful, thank you. Yes, so welcome everybody. Thank you for taking the time. And Liana, thank you for your presentation as well. As Liana said, over 70 different types of neuromuscular conditions and things. So here's me sat in front of you now with just one chair. I am not going to attempt to cover the range and vastness of how many different types of conditions there are and what you would do, but I am going to pick up on a couple of key ones, or a couple of good general things that we look for, that I look for when I'm assessing. I did want to have another chair with me today to kind of discuss the muscular dystrophy side of things, but we will go into a lot of detail on the motor neuron disease side of things as well with the chair you see here. On the muscular dystrophy side of things, I think the key thing for me, and Liana mentioned this as well, it's understanding where we are in the line, in the timeline of things, how we're progressing. Often when I am met with a muscular dystrophy side of things, there's still a level of mobility, but we're just kind of struggling to get that transfer up and out of seating, and we need a good level of support and pressure care to actually keep that person comfortable and going for as long as possible. So those are the kind of key things I'm looking for. So one of the chairs we provide is actually a vertical rise chair. It's a rise recliner chair. We line it out with the best pressure care that we can. We can modify the cushioning at the back and make sure it's all kind of supporting as it needs to. But the key feature in it is that rise function. What that ends up doing, with it coming up vertically, and it comes up some way, we can go up to, I think the last one I did was 36 inches of vertical rise. The chap I was dealing with was particularly tall, but what we want to do is want to get to that point where the chair will rise, and then we will actually be able to lock the knee, and that patient will then be able to move and walk about and have that independence for that little bit longer. And you do also have the ability to hoist into that should you need to at a later stage. As I say, apologies I don't have the chair with me, but just to give you an idea, the key thing in it would be where we are in the stages of the condition, but also what are we wanting to achieve. And most of the time it is that independence we're looking for, and it is that good rise on the chair that will lock the knee and give them that mobility. The main one though, or main condition I want to look at and discuss with you today, where this chair comes into it, is the motor neuron disease side of things. Now, some of you will, if you've been on these webinars before, you will see this chair and you'll just think I'm cutting corners, pointing to the same chair again and again. Yes and no. It is the same chair that we may have seen on other webinars, but there's a real reason why we designed it the way we did, and there's a lot of application to this. So what I'll do, I'll go through some of the key basic features of this chair, but then we'll get into the conditions of motor neuron disease, okay? For me personally, I actually have a brief story before we begin of there was one particular OT I work with very closely. She'd never heard of us before. She had a conversation with me about a couple of key patients that she was struggling to seat. They all happened to have motor neuron disease, 6 of them in total. I discussed this chair and a couple of the extra accessories that could maybe help support them, and she gave me a shot at trying to seat them. Unbeknownst to me, this was a big test as to whether she would ever use us again, so I was quite grateful I didn't know that at the time. But we went to each individual person, and with tweaking and in the basic adjustments, but also adding to the accessories around that, I can honestly and truly tell you that we managed to see every one of her patients that she'd been struggling with for weeks, and every one of them was still using it to this day, and very happy with the results of what the chair managed to do for them. So I say that to begin with, and we'll go through now some of the features, and hopefully, as I say, if you've got any questions or if there's anything you want to know in more detail, please just pop a question up and we'll tackle that. So this chair has been designed to be adjustable in a number of different ways, without the need of tools, and to just give a wide range of support to a range of conditions. We would say on average it suits about 80% of people that need a chair like this. Now, what we have in this chair is we have got, I say 4 levels of adjustment. My manager would say 5. I'll let you decide on the last one yourselves. We have got depth adjustment. So at the back of this chair, we have the ability very quickly to take this pin out from the back and we can then move this chair forward or back depending on what we need. I'll bring it round so you can hopefully see on the screen. It's not the easiest thing to spot, but by adjusting or pushing the chair forward and back, we can actually get that seat depth where we want it to be. Okay, so again, going back to Liana's presentation, we want to make sure we're getting the femur well and truly supported. This chair gives that ability very quickly. Also, what we've got here on this chair is the ability to adjust the seat width. We have up to 22 inches of seat width as standard, and you can go into about 15 inches in seat width if you need to bring it right in. So again, you've got the option here to adjust accordingly to what you would need in that respect. If I take the arm off completely, we then have the ability to adjust the seat height. Again, Liana, you've made this very easy for me. You can just basically pick whereabouts you want that arm height to be. Once you're happy with that and it's supporting the client's shoulders and giving them a good spread of pressure in the right place, you can set that up and lock that off. And once you've done that, you just tighten the screw underneath, out of the reach of everybody, and you're good to move on. I'll move this back up a bit higher for something to come in a moment. Right. The next thing we have our leg elevation here, and we also have the ability to adjust our foot plate height. So again, Liana mentioned it in her presentation, the need to make sure the feet are well supported, whether that's on the floor or on a foot plate. In the case of motor neuron disease, it is often the case you would be using a foot plate you'd be hoisting the patient in, and they would need that foot plate to support their feet. So you have that ability to do that there. If their feet weren't quite reaching within the range that we have, we do have the ability to add a supportive cushion over the top that fits in line and just gives that adequate support and comfort. So, if you've been counting with me, you'll have seen we've got the seat depth, we've got the seat width, we've got the arm height, we've got the foot plate height. Those are my 4. Now my manager would say to me, yeah, but Ben, we can also adjust the back height. And he's right within a reason. I will have this conversation ongoing with him. By adjusting the cushion height, you can cushion round, you can get a couple of extra inches of height with the cushion there. Is it an adjustment? I don't know, but it is a very nice feature to have. Now, if you're looking at this and you're saying this is all very, very manual, you're absolutely right. A lot of the time what we would do is set and adjust the chair to the right dimensions of the patient and hand over and do any training for anybody that's caring and may need to adjust it at a later date. But most of those things you would do and set and they wouldn't need to touch. We do also have tilting space within this chair. Now that is a key feature for anybody that's sitting out for long periods of time. Again, we want to make sure that the person we're dealing with, why are they wanting to get in the chair? Most of the time for something like this one, and for motor neuron disease, they want the comfort, they want the quality of life, they want to be with their family, they need to eat, they want to relax and watch TV with everybody, they don't want to feel like just the other person in the room on their own, they want to be involved in what's going on around them. So again, as Liana said, it's very important that, and it's a big aspect of why this is so popular. So that function there, it is on manual on this particular chair, but you can power that. You can motorize every function on this chair. So you've got your tilting space, you've got your back angle as well, and you've got your leg elevation. All of those can be powered. So you can have the remote. The remotes are usually magnetized to the side, so there's no loops or anything else, which is a huge relief because a lot of the time you work hard to get that person well and truly supported, pelvis nicely back in the chair, you know, everything supported, depth, width, all done nicely, and then they're trying to find the remote and they're leaning over. You don't want that because then posturally you're in a bit of a pickle. So having a magnetized strip there just ensures that it's just a quick reach, they can find it and they can use it. Beyond that as well, we do have also the ability to link this up to eye gaze technology. Again, Liana mentioned it very briefly. As these types of conditions take hold, there's not the function physically to do anything. Often it's all through eye gaze and through technology, and that all plugs in and ties in very nicely with this chair. We can link that up and people can still function. They can tilt themselves back when they need to, they can bring themselves forward, they can still have a level of control over a condition that is quite obviously very difficult to deal with. Now, that's your basics within what you have here as standard. What I tend to find is that you obviously then need to adapt as things progress. And one of the biggest things is to support the head of the client, really. And so one of the things that I absolutely love and find really helpful is this particular head support here. Now, I don't know how close you can see this, but basically what we've got links all along the back here. It's attached to a bracket. So what we can do, we can slide this along either way if we need to. You can basically control how many links you have, where you want these all to rest and land, and basically we can really get into and support the client's head with this particular piece of kit. As well as that, what we can do is we can actually close it in or open it out depending on what we want. We can add links to it and we can leave links off. So if a patient is constantly leaning to this side, we can bring it right round here and then open up this side so we're not restricting that person's view. They're still able to see, function, kind of get some sort of support there. We can add padding inside if we need to. There's a lot of things we can do with this, but ultimately this just helps to control that, especially if you've got eye gazes in the situation. We want to make sure they can access that at all times. This just ensures that we're keeping that head well and truly supported. There are a number of other things that we might need. You might need to increase, as things progress, you might need to increase the support that we put around the trunk of the patient. So having a thoracic lateral might be something we need to introduce, which you can add on here quite easily. We might want to change the cushion. We might want to have a bit more of a shaped cushion that's just lending a bit more support to the pelvis. There's a whole host of extra bits and pieces that you may require. We might need chest harnesses, we might need other things. Now, again, for me, it's about understanding, as Liana said as well, it's understanding the situation, understanding what are they needing it for. Of those 6 people that I mentioned before, one of the chaps that I was dealing with, he just wanted to sit with his family and watch movies with them. They had movie nights and that's what he wanted to do. And so there wasn't so much all the extra support. He did need it to be powered so he could change anything if he needed to, but the main thing he wanted was to just sit comfortably with his family. And so what they did, they bought a suite of sofas that looked very similar to this chair, had one either side, him in the middle, and he was able to tilt himself back, everything else. They took a picture of him there with his movie night, with his popcorn and all that sort of stuff, and just enjoying being out of his bed and actually in a chair that was comfortable, that was supportive, that was catching him in every place as it should. Final thing to mention on this, it is Dartex in the middle of the chair. What we do though, we would always in these instances look to provide a high cool gel into the seat cushion, which does kind of help combat the sweat that you can sometimes get from these chairs if people are naturally not good at regulating body temperature. You know, we can line it up with a cool gel which kind of tackles that a little bit as well. But ultimately what this does is it gives freedom to change position frequently, it gives them the support they need, and you've got the peace of mind to know that if things change, because this is a progressive condition, you can adapt and add to. You're not having to buy another chair and hope it works and then buy another chair. You can tweak, adjust, add to. So it's keeping it cost effective, it's comfortable, it's reliable, it's supportive, and as I say, we had that incredible success rate with those 6 patients that this lady I was mentioning had struggled to seat for a good number of months before meeting us. So it does work, and this is one I would generally go for. I hope that makes sense, but if you've got any questions, I'll hand back over to Braden.
Brilliant, thanks Ben, that was very helpful, and there's a lot of very good questions and comments coming on the chat now, which I'll run through. So I'll open the floor to yourself and to you, Liana, again, and we'll just go through those quickly. So firstly, we've got one from Joanne. Is cerebral palsy a neuromuscular condition? Might be one for you, Liana.
Muted there, isn't she? Yeah.
I'll ask you to unmute. There you go, and see if that brings up a thing. There you go.
Yeah, thank you. Sorry, I don't know why it's doing that. Yes, muscular this CP is a form of neuromuscular condition. Its origins, of course, sits in brain damage and neurodevelopmental sometimes. So, but yes, it is, I think, is classed under the neuromuscular disease family.
Yeah, okay, that's interesting. Thank you. We've got another question. Do we have a list of charities that would consider funding chairs for clients with neuromuscular difficulties? So, Liana, you probably know of many charities. We've actually do have a charities list on our website as well. So we can make that available in the follow-up email that we send around to everyone to have a list of that. But I'm not sure if you've got any specific charities, Liana, which you found to be really good.
Do you know, to turn to us is really not a bad one. Sometimes also we found some of the local Rotary clubs are really good at helping people. Lots of the standards, so the MNDA and those type of charities used to have a lot of funding, but they don't have as much. But some of them still do have like grants you can apply for. So
Okay.
it does vary. Unfortunately, it is a bit of a try different. Sometimes what we've done is we've gone to different pots. Instead of asking for one big pot of money, sometimes they're willing to give you smaller pots. So they mix all the pots together. It's hard work, but it's quite rewarding in the end.
Yeah, no, that's very helpful. Thank you. And then just quickly going back to cerebral palsy, is it a non-progressive condition?
Yes, it is. But what we find is the older they get, as your brain gets older, their problems get worse. So if they've got a lot of spasticity already, what we find the older they get is the worse the spasticity get, the worse the symptoms get. And I think it's predominantly unfortunate as our brains age, it's just sort of an increase in the damage. And you have to sort of equate for that. So you might have someone who is just happy with, doesn't need a lot of support, but as they're getting older, we are finding that they need more and more and more support as go on, purely because of, as I say, as your brain gets older, for some reason your brain just seems to then make the damage go worse.
Yeah, okay. Claire, I can see you've got your hand up. You've got something to say. Feel free to unmute. Sorry, I've just...
Is that unmuted me?
There you go. Yep, we can hear you.
It was really just to add to that charity list thing. So I work for Spinal Muscular Atrophy UK, the charity. So in terms of funding, we do grants, but they're quite small grants. So and what we would always do, so and we would obviously only support anybody that's got SMA, but if somebody had exhausted funding through statutory means and the chair was deemed to be beneficial, we would look at that. But I mean, our flexible grants probably are up to a maximum of £600. So we find that we're having to go to multiple charities if we need things funding. I'm conscious MD UK have not got as much money as they used to have. But yeah, I think it's getting tough out there for funding. We would always absolutely push for CHC funding or as a non-stock item through stores if it was a clinical need. But we have got grants. So yeah, if anybody's got people with SMA.
Brilliant. Thanks very, very much, Claire. I appreciate that. That's helpful to know. And thank you to Catherine as well, who's put a comment on the chat saying the MNDA of a care grant of up to £900 that can be used towards funding a chair. So that's great to know. Thank you. Brilliant. Thank you very much, Claire, again. I've got a few other questions here. We've got Holly and yourself, Claire, talking about young adults and paediatric options as well. A lot of young adults saying that specialist chairs often look too clinical. So looking for options for them. Ben, you could probably talk about this a little bit because we do have a paediatric option, don't we?
We do. There is a paediatric version of this chair. So there's a couple of people asking what the chair's called as well. This is the Lento care chair, Lento care chair. We have an adult's version and a paediatric version, so we can mix between the two. In terms of colours, you can pick and choose what colours you want. We do tend to be limited on the inside colour, the Dartex there. It does tend to be a lot more limited in terms of what you can do there. But on the outside, yeah, we've pretty much got a good range. The one you see in front of us, it's kind of like a faux leather on the outside. And then obviously Dartex on the inside. That's just from a cleaning purposes and things like that. It tends to be more straightforward for people. But we do have even fabric options if you wanted to, like different types of velvets. We have a range of different things we can do and have done to just make it less clinical. A lot of the kids that I see, they like it because it looks a lot like a gaming chair at first kind of glance and look, which maybe we should advertise it as such, I don't know. But it really does kind of help soften things in that sense. There is always going to be a level of clinicalness to these types of chairs, unfortunately, because they are quite high grade, but we have worked incredibly hard to try and make it as homely as possible. It's just unfortunately that sometimes we need to take that step. It is providing a medical need. Hopefully that answers the question.
Yeah, brilliant. Thank you. And then Claire also mentioned again about the pressure care needs. So again, within these chairs, we've got various different options, haven't we, Ben?
Absolutely. So I mentioned most of the time we're going with a gel cushion. Our basic is kind of like a visco foam. So like a medium sort of relief. We have a gel, which is high, but then we can just, with the types of chair this is, you literally just take the cushion off and then you can upgrade it very quickly to even like an alternating air cushion. So the same technology is in your mattresses on your bed. You would basically have that plugged in, and you'd have a battery pack at the back that is constantly oscillating inside the cushion to ensure that that patient is still getting a good level of pressure relief. And because it's on a battery pack, you're still mobile as well. We do have ones that plug into the wall, but most people, because they want to go out in the garden and be near the family when the sun's out or near the barbecue, because they want to come in, watch a movie, because they want to be in the kitchen, we purposely kind of prioritize it being a mobile battery pack there to ensure that they're able to continue doing what they want to do. Last thing we want to do is hinder them with anything like that.
Brilliant, thank you. And then thanks to Anthony as well for the comment on the chat saying Kent have a joint funding panel, health and social care, that meets weekly to approve seating and other equipment deemed required by a clinical justification form. If it's rejected, we can also approach the ICB funding team for support. So thank you for that, Anthony. Brilliant. I'm not sure if anyone else has got any other questions that they would like to ask at this point. Again, we are also very, very glad to hear from you after the event as well. Reach out to any of us afterwards, call one of us in the team or drop us an email, and we can get back to you with any questions that you do have and further information. Okay, there's no one coming up right away. So, okay, I will just share screen again. And we will move on to the final few slides. So thanks again to everyone. We'd like to just point out that we do have a huge amount of resources on our website. So we've talked about the charities list, which is available in the downloads section of our website. But within our resources section, there's a huge amount of other things as well, which include a seating assessments form, which you can download or print and actually use it when you're on an assessment to go through all the different elements that need to be considered for during the assessment. It also includes many, many blog articles about specialist seating. We've actually got justification forms as well, which have been partly filled out in relation to the different chair options. So you can use those if you're trying to get funding. And also we've got a collection of helpful training videos and recordings of previous webinars. So there's a huge amount there to go and have a look at if you have the time. And then please do also remember that our team of in-house seating assessors can join you for assessments upon request if you need it. Who they can actually come. It might be Ben or it might be Ben's colleague Harry, who come out with chairs following a call that we might have about your client, and we can look at options and they can give it a go, and that's free of charge. So please do reach out if that's of interest. And you can book this by either going on the website. We've got an assessments page, so vivid.care/assessments, or otherwise just give us a call in the office and we can get that booked in. So future webinars, we will be circulating a recording of today, so you can have a look at that again if you like. Go back over the presentation, and we will include a copy of the PowerPoint as well. I know a couple of you put that comment on the chat, so you'll have all access to all of that in the email. But our next episode, episode 8, will be mastering seating assessments for people with Parkinson's disease. So we'll be launching the registration for this in the next week to 10 days. And that will be in about a month's time or just over. So you feel free to go and register for that. I'd be glad to see you again for this one. So with that brings us to the end of the presentation today. Thank you again to Liana and to Ben and to everyone for joining and all your questions. I hope it's been of some help. Please enjoy the rest of your afternoon, and thank you again.